Good morning. Today we'll be talking about cervical cancer. Thank you, Dr. Olaleye, for coming and joining us on this program. What is cervical cancer and why are we so worried about it?
Cervical cancer is a global health concern for women. However, in other parts of the world, they're doing something about it. Sadly, we are doing the proverbial ostrich in Africa, particularly Nigeria, the most populous African nation, basically burying our head in the sand while a mother, a wife, a sister is being taken away from us every hour by a disease that's 100% preventable. So as of today, we've lost almost 10,000 women to this silent killer of our women. So 24 women will die today. So multiply that by 365 in a year. You can just do the sums. The math is really dizzying. Now, these women are just dying needlessly. And the sad reality about cervical cancer, which is actually cancer of the cervix. So you want to ask me, what is the cervix? The cervix is the neck of the womb, where, as women would imagine, their menstrual flow comes out every month. A sperm cell goes, our sperm semen would go in, fertilize the egg, and they will deliver a baby through that same cervix, and then close and shrinks back to normal size after delivery. But the neck of the womb, as it were, a very tiny, very, very, very important part of the woman's genital tract, is so easily forgotten because women don't see it. But it's there. And sadly, when they get infected with HPV, the human papillomavirus, the virus that causes this cancer, they are none the wiser. And the cancer develops over 5, 10, 15 years, which therefore gives us an opportunity to be able to identify the disease, because cervical cancer is one of the only cancers that have a precancerous phase, a phase that's as long as 15 years. So from a public health point of view, it's really an opportunity to identify women before they have the cancer. And we are missing that opportunity in Africa. We are missing that opportunity in Nigeria.
What does precancerous mean? How should people understand what is precancerous, what is cancerous? I mean, you've highlighted something that's absolutely important and people need to understand that better.
Unlike other cancers, cervical cancer actually have a before cancer phase that can last up to 10, 15 years. So we call that pre-cancer or precancerous stage. In fact, they are very well identified stages that we number them 1, 2, and 3 from a pathological point of view. So they are called CIN1, CIN2, and CIN3. These 3 distinct phases collectively form the pre-cancer stage or precancerous stage of cervical cancer. And it can take 5 to 15 years for that to develop in a woman. When it becomes cancerous, that's when we actually call the disease cervical cancer. So a patient of mine who you would interview later actually had precancerous stage 2, CIN2. So she didn't get to cervical cancer. And that's why today we'll be able to invite her on the show to talk about it.
Thank God.
Otherwise, she would have been, exactly, thank God for that. Otherwise, she would have been one of the statistics of women who have been told, Madam, we are very sorry, you've got cervical cancer. And that's the sad reality of cervical cancer. Because once you miss the precancerous stage and the diagnosis is now cervical cancer, it's a death sentence. It goes downhill from there. Because the cervix is a very small organ, but it's surrounded by vital pelvic organs. So it spreads very quickly and it's not amenable to treatment. Unlike when it's precancerous, when we can easily identify it and we can remove it. Like our patients that will be coming on later will confirm. She's all clear now. She's had a 6-month follow-up and she's all good to go.
That's fantastic. And I think it's understanding this, that we can then put things in context with what they do abroad and what they do here. Because the whole issue of screening is to pick up that precancerous stage, isn't it? So what is it
Absolutely.
that they do abroad that is different from what it is that we do here? And how can we make that transition? Can we make that transition? Can we get there? Is that something that's achievable?
5 decades ago, when, or almost 6 decades ago, when George Papanicolaou, the pathologist, the Greek pathologist, discovered through his seminal study of precancerous lesions of the cervix in Catholic nuns, and discovered that actually cervical cancer can be picked up years before. He went backwards to now identify what needs to be done, which would be screen women. Basically, drag all women that are sexually active through a smearing process, which is now called pap smear, which is actually from his name, Papanicolaou. And then doctors will be able to identify women who are shedding abnormal precancerous cells from their cervix when they are tested. So developed countries, the abroad countries, saw this as a vital opportunity to save their women 5 years before they're given a diagnosis. So they put the infrastructure, training, and the financing that goes into telling every woman, inviting every woman, and getting every woman tested. You see, there are 3 stages there: informing, inviting, and testing them. So the infrastructure for informing will be public health campaigns. The infrastructure needed for inviting will be a good poster system or communication of everybody on the public database, the population database, the census database. So in abroad, they use the postcode. Everybody who's got a registered address as a GP, and they are written through their GP, and they are invited, and the GPs now invite them. Again, there's a massive cost just for that alone. And then you now test these women, and you have good network of laboratories that will run automatically specimen collected by these women. Then you get these results analyzed, you identify those who are given abnormal results, invite them for colposcopy examinations, which basically means seeing a specialist in a teaching hospital or a general hospital, a gynecologist particularly. And that was the role I used to play in the NHS. I used to sit in the colposcopy clinics on Fridays, seeing these women that the GPs had seen months before, and they've come through the system, identify where the abnormal cells were being given during smear, and treat this women, and then send them back to the GP. So for our country in Africa, or most African countries, we're not informing our women. We're not inviting them. We are not testing them. And there's no clinical pathway for them, no care pathway for them, for those who test positive. There's no colposcopy clinic for them. And therefore, what I would recommend, and this is why we had that discussion 10 years ago on the flight, you said, Dr. Olaleye, start small, start talking about this. And that's what I've been doing. As an NGO, which basically is my foundation, Optimal Cancer Care Foundation, through partners, through people like you, we've been raising awareness, which is basically informing the women, then inviting women, making it easy for them to get screened. So on every Friday, we offer discounted screening. It used to be free, by the way. And I remember Doctors on Here and a few other organizations like You Champion have invited us to offer free screening to women on special days of the year. That is what we are doing, but it's not good enough because we are actually just scratching the surface. There's still lots of women that we have not reached. We're only doing this work in Lagos, a small corner of Nigeria, a very vast country filled with women, millions of women. So government really needs to step up to this plate and say, women, we recognize you form the bedrock of society. Any decent society recognizes that. Therefore, can we do something for you, specifically with regards to cancer prevention? And the first thing government must do is set up a ministry or an institution or an agency on cancer screening. Just like that was done in the NHS. The NHS exists, but there's an NHS cancer screening service that's totally funded, separate from the NHS. So Federal Ministry of Health needs to design an agency or construct a ministry or an agency that delivers cancer screening. The same way we've done with HIV care. So we have NACA, then SACA, and then LACA, which is federal, state, and local government. We can design something like that, and then we can get to that woman that's selling pure water on the street, that woman that is frying corn at the corner, that woman that's working in your office, and that woman that's working where I'm sitting right now, serving me a drink before coming on. So really, we need to pay all our women, particularly those who are already sexually active, to know about this. Basically, you have a cervix that's oozing blood every month when a woman has already stopped menstruating, and that comes out of a private part as a menstrual flow. Most women will not have pain, so they will not associate it with anything ominous, and they ignore it for months because it's not painful, it's not disturbing them from doing anything, and that is a red flag. Because the longer you live in it, the more dangerous it becomes and difficult to eradicate. So postmenopausal bleeding is a symptom. If you're not postmenopausal, meaning you have not reached menopause yet, you could be having discharge. Basically, the cervix is oozing some foul-smelling fluid, which really it's another warning to you that something is not right down there. Then again, some women discountenance that, and they say, oh, well, maybe I have an infection, maybe I have a toilet infection. They go up to the chemist and use some medication. That is not appropriate. What you should do is get tested. Some women do get what we call postcoital bleeding. The woman's cervix is like the skin, very strong. The lining is very strong. It should withstand the brute force of intercourse. So women really should not bleed after intercourse. So if you're bleeding after intercourse, it's telling me something is not right with the covering of the cervix. There are other reasons why women bleed anyway after intercourse. Could be just bruising or maybe some infection going on there. But again, that is a red flag. But ominously, the biggest killer of women with cervical cancer is not bleeding, is not discharge, is not postcoital bleeding. It's actually renal problems, kidney failure, because the cervix is so close to the pipes that we call the ureters, the pipes that drain the kidneys to the bladder, and they loop around the cervix. And when the cancer is spreading without bleeding, that usually gets snagged and caught up and blocked. Urine now backtracks up to the kidney, and the woman starts presenting with symptoms and signs of what we call uremia, kidney failure. So again, a woman with kidney failure needs to get checked to be sure the problem is not coming from the cervix. We doctors call that obstructive uropathy. And really, that's the commonest cause of death of women with cervical cancer, not the bleeding, but from renal problems. So I've painted a very dismal picture, really, of women going through this painful ending towards when they have a diagnosis of cervical cancer. But the good news is it doesn't have to be that way. Almost all women that are sexually active have a chance to stop this disease dead in its tracks. All they need to do is just put up with it uncomfortable. And I could use that as a relative term. I'm a man, so what do I know about a woman getting examined? But some do complain that, oh, it's a bit uncomfortable. Yes, just put up with this uncomfortable examination every 3 to 5 years until you are 65.
Can the use of condoms prevent HPV infection, which leads to cervical cancer?
HPV stands for human papillomavirus. It's the commonest sexually transmitted virus in the world. It's a virus that is transmitted through genital contact, through sexual intercourse, and sharing of sex toys as well. And it's a virus that stays commonly as a normal flora on the bodies of men. And during sexual contact, then we get this virus across to women. Condoms is worn only on the genital, the penis of the man, which therefore renders it totally useless in preventing the transmission of the disease, of the virus to women. Because, during sex, as you know, it's two bodies coming together. And like somebody said, if it's not wet and rough, you're not doing it right. So if you're doing it right, then you are actually transmitting cervical HPV to the woman. So the answer is no. Women continue to be at risk from the minute they become sexually active for the rest of their reproductive lives. The global campaign against cervical cancer has recognized 3 main ways to screen women for cervical cancer. So LBC, which is a modern, much improved way of doing pap smearing. Before, it used to involve taking a smear, putting on a slide and sending it to the pathologist. Now you actually use a brush to take the sample, put in a pot, and send it to the pathologist. So that gives you more cells to look at, and the pathologist will have more tissues or cytology to do. And the cost implication of that has made it difficult for low resource economies like ours to actually get into a public health, set up a public health system that will deliver LBC across the population. So about 8-10 years ago, a team of scientists, gynecologists and epidemiologists from King's College London, led by Dr. Adeola Olaita, and I was involved with that as well. We came to Nigeria and we tested a method that's been tested across other low resource economies like India, Mexico, Brazil, South Africa, called VIAA. VIAA stands for Visual Inspection with Acetic Acid. Actually, it used to be an integral part of doing colposcopy examinations, but we decided, let us actually use this method to screen women. Basically, instead of using smearing, spray acetic acid, which is a very diluted mix of acetic acid and water on the cervix. A reaction on the cervix, viewed by somebody who's trained to identify what's normal, what's abnormal, can pick out women with abnormal changes. And then you can obviously offer them treatment or a biopsy. And that method is called VIA. In my clinic, we actually support that with colposcopy, which means you get to see your cervix on a screen when we have done the VIA. So that has been accepted by the WHO as a screening method as well. And the last bit is actually more recent, about 2 years ago, and probably pushed by the Americans, who basically responding to their female population saying, I really don't want to go into clinic and be told there's something wrong and I don't have HPV. If it's HPV that's causing this, can we do HPV DNA analysis for us? And of course, they designed testing kits for HPV DNA, the way we test for coronavirus. And we have been able to identify this as a screening method as well. Sadly, there are 13 to 15 oncogenic HPV viruses. That means HPV viruses that can cause cervical cancer. We call them high-risk HPV viruses. And you can pick up an HPV virus in a woman that is low risk, but that doesn't mean she's at risk of cervical cancer. Or you could pick up a HPV virus in a woman that's high risk, but again, she might not be having changes on her cervix as well. So in America, they've designed what we call co-testing, meaning if you do pap smear and you do HPV DNA and your results are good, you can come back in 5 years' time. Which is the answer to your question, whereby you ask what happens if you've done a test and when do you need to come back. However, in our low resource economy where you use VIA, visual inspection, women can't afford LBC, women can't afford HPV, then you will need them to come back every 2 to 3 years, which is what I recommend at my foundation, that when I screen women and I look at their cervix, they're looking good, I say, Madam, see you in 3 years' time until you are 65. And that is the answer to my question. Vaccines are designed to prevent diseases. And since we know cervical cancer is caused by HPV, HPV vaccine has shown that HPV-related diseases like genital warts, cervical cancer, anal cancer, rectal cancer, penile cancer have been nosediving in countries where they have widespread vaccination. So it's been a very good investment on those countries, in those countries. However, in Nigeria, we don't have a national funding strategy to give HPV to all our women, particularly young girls. So therefore, our women have been advised to take HPV vaccines at their own, out-of-pocket expenses, and it's been a tough one because there's not been a national call for women to do this. But the question that you asked about how effective are they, what's the role of HPV vaccines in reducing cervical cancer? The impact study we just published last year from United States Impact study, you can Google it later, has confirmed that over 10 years, the efficacy has now been proven that HPV vaccines do indeed reduce the incidence of cervical cancer. In
So is it like
asking you a question.
No, please carry on.
I wanted to ask the question.
Yes.
I wanted to answer the question about, can you still infect people when you've taken a vaccine? The answer is yes. The vaccine is only preventing you from developing cervical cancer, but you're still, I'm sorry to say, you're still hosting the disease. You're still hosting the virus. You can still share it. Your sexual partner can still share it. Fresh ones can still come to you, which is why if you're already sexually active before taking the vaccine, you have to continue doing the testing, because there are different strains of this vaccine, of this virus. And most likely the vaccine would have covered maybe one or two common strains. Sadly, the vaccine that's commonly available in Nigeria covers just two strains, 16 and 18 HPV. And though the other viruses are what we call phylogenetically related, that means they belong to the same DNA tree. So they are related, they are families, they are cousins. So you might get covered by them, but we don't have a guarantee on that. So if you're really sexually active before taking the vaccine, we would advise you to continue doing the testing for at least 10 years, so that we know, you're good before you can say, okay, I don't want to go for testing anymore. And moreover, the testing would have just been spread out for once in 5 years anyway. So, there's no harm in checking every 5 years to be sure you are very safe and your vaccine is up to date. It's something that you need to do every the first month of the year. In fact, the United Nations and the World Health Organization, in their wisdom, chose January, the first month of the year, for women to go get screened as the month of cervical cancer awareness. And that is the reason why it's important for us to make this a national project, a state project, and at local government level, so that we can percolate to all women in this country.